Good afternoon, everybody. My name is Ashish K. I'm the Dean of the School of Public Health, and I want to just take a couple of minutes to get us started, and then I'm going to turn it over to my colleague and friend Andy Ryan to introduce the panel and get going on the conversation. But I want to start off, the conversation today is really focused on private equity and its implications for healthcare, but the conversation today goes in many ways beyond that, right? And where I want to start us off is talking about this new center that is being launched at the School of Public Health, why it exists, and what the issues are that it's going to be facing. So why do we have a Center for Advancing Health Policy through Research? And there's a few words there that I want to talk about. Healthcare spending, about $4.3 trillion, close to 20% of the GDP of the United States, represents, in my mind, the biggest social policy challenge facing this country. Not the biggest health policy challenge, but the biggest social policy challenge. You're like, well, that's bold. Why do you say that? Because as healthcare spending has continued rising, it has had a very clear impact on crowding out all sorts of other things. So if you look at a state just north of us in Massachusetts, and you look at what has happened over the last 15 years, healthcare spending is up about 70%. Spending on education is down 40%. Spending on infrastructure is down 50%. Spending on human services, welfare, is down about 30%. As healthcare spending rises, especially at the state level, and budgets don't rise commiserately, that money comes from somewhere. And if we think that the most important thing we could be doing right now is taking money away from education to put into healthcare, then you should be good with this. But for those of us who look more broadly at society and say, are we optimally using the resources we have? It is very clear that we are not, right? So the trade-offs of high healthcare spending are very, very real. And they show up in pretty much every part of the national conversation. We often talk about how wages have been stagnant. Wages have been stagnant. Compensation has not been stagnant. Compensation for workers has been rising, but it's been going into healthcare dollars. There are real social impacts of the incredible amount of money that we spend on healthcare. And it shows up in everybody's daily life, right? $200 billion of medical debt. Most of that medical debt carried by people who have health insurance. So this is not just a problem of the 9 or 10% of Americans who are uninsured, but the insured in America are facing an exorbitant cost. Obviously, we see the impact on state budgets, the federal budget. The US government and the states are spending close to $2 trillion on healthcare between Medicare, Medicaid, VA, DOD, everything else. And then if you throw in the subsidies for private insurance that exists, the cost to budgets, companies, everything is very large. So that is the problem in front of us, this very substantial problem. How do we get out of it? Well, it's a behemoth of a problem, so there is no silver bullet. But this center, right, it's a Center for Advancing Health Policy through Research. It is predicated on the idea that if we're going to make progress that's sustainable, that's actually going to move the needle, it has to be data-driven. Because if you go to Washington and you lay out this problem, you will immediately get everybody giving you their favorite solution. And they are convinced that if only the world would listen to them, this problem would be solved. And almost all those solutions are data-free. And it turns out that this is a hard problem, and hard problems need evidence and data to drive it. And so this is true today. It was also, by the way, true 2-3 years ago. And so a couple of years ago, I was sitting with the provost of Brown at the time, Rick Locke, and we were talking about this problem. And we were talking about the need to tackle this and the need for Brown to play a leading role in this. And Rick said, well, how are we going to make that happen? And I said, I know a guy. I did know a guy. His name is Andy Ryan. And that began an effort to get Andy to leave that small state school in the Midwest and come to Brown Look, the reason to have Andy lead this effort is it is actually hard for me to think about or think of anybody who has been more impactful, more creative in thinking about the payment systems we have, the ways in which it sort of distorts good behavior, the impact of all of the changes that we have seen since the Affordable Care Act more than a decade ago. Andy has been at the forefront of this work. And so we were thrilled, I was thrilled, Rick was thrilled when Andy agreed to come and start off this new center. So we have phenomenal leadership. There are lots of different places where this can go, where Andy has really put a lot of his effort in recruiting a great team and collaborators, many of whom you're going to hear from today, is really thinking about the payment side of things. How do our payment systems promote or at times, discourage really good value-based care? Last point I want to quickly make, and before I turn it over to Andy Ryan, is the conversation today is about private equity, and this has gotten a lot of attention. Just a couple of weeks ago was the FTC thing on, and my view is that private equity is just a symptom of the problem. That we have such an incredibly broken market-based, quasi-market-based system that it invites predatory behavior. It sets up a situation where people who just want to come in and make lots of money find lots of opportunities to do that. And we can try to go after private equity. I'm fine with that. But to me, that is ultimately treating a symptom. And sometimes you want to treat symptoms, by the way, so that's okay. But you should never confuse treating symptoms from treating the underlying cause. And we have very substantial challenges, but we're going to make progress really through driving evidence and data. And there's no better group to talk about those issues than the group that's in front of us today. So let me turn it over to Andy Ryan to get us going. Andy, over to you.
Well, thank you, Ashish, for that extremely eloquent introduction and setting the stage for the many problems that we have and we're trying to address. So welcome, everyone. I'm so thrilled to introduce the Center for Advancing Health Policy Through Research, known as CAPER. So as Ashish mentioned, the mission of CAPER is to generate the highest quality evidence to advance informed discussions around healthcare affordability, access, and value in the United States, and to translate this information towards policy change. And so Ashish talked about the need for evidence, and I want to emphasize the need for policy translation because, so often academic research remains sequestered in peer-reviewed journals. It doesn't get to the policymakers and community stakeholders that are trying to drive change. And so this is something that's important to us and something that we're really trying to address in the center. And how we're doing this is through targeted dissemination to policymakers and engagement with the community of stakeholders and policymakers. So this leads me to today. So today is a very special day for me. Not only are we launching this new center, but it's my wife Mandy's birthday. And it's our anniversary. All right. And what better way to celebrate than a panel discussion about private equity and healthcare? So why are we talking about this? So historically, and with many exceptions, healthcare providers, so physician practices, hospitals, nursing homes, have been independent entities. And while there's been a wave of consolidation in recent years, corporate ownership of these entities has been quite limited. But this is changing with private equity. So in private equity, investment firms purchase mature businesses like physician practices or hospitals or nursing homes, seek to revamp them and then resell them in a short period of time. And, what does this mean for healthcare to have these new ownership structures? What does it mean for patient care, for system outcomes? Well, this is what we're going to be discussing in our panel tonight, and we have a really outstanding group of colleagues that I want to introduce. So first, we have Chris Whaley. So Chris is a professor at the Brown School of Public Health, an expert on markets and regulation in healthcare. We have Yashaswini Singh, who is also a professor of public health at Brown, an expert on private equity. Aaron Fusay-Brown is the Catherine C. Henson Professor of Law at Georgia State University, an expert on health and administrative law, and a friend and colleague of the centers. And then Corey King, who is the acting Health Insurance Commissioner of Rhode Island. So each panelist will give some brief remarks, after which I will moderate a discussion, leaving time for audience questions. All right, so Chris, you are the first speaker.
All right. Do you want us to come up? Or
Yeah, why don't you come up?
All right. What Andy did say is that this is actually supposed to be next week, which I learned later is not his wife's birthday or his anniversary, but it was I who had a conflict. So thank you, both Brians, for rescheduling for my schedule. So I want to kind of lay the groundwork a little bit and set the stage and take a step back. And to do so, there are a couple points about the healthcare system in the United States that we should make. First, there have really been 3 waves of provider consolidation in the United States. Roughly, 1995 or 2000, we started with this kind of merger boom of hospitals acquiring each other and getting bigger and forming these mega healthcare systems that we're still living with today. So if we look across the landscape of U.S. hospital markets, nearly every single market is well above what regulators like the Federal Trade Commission or the Department of Justice would consider very anti-competitive and not a healthy market in any single other industry. But healthcare is kind of a unique exception where we're willing to kind of live with those effects. The second really wave of consolidation started around 2010, where hospital systems really recognized that they've kind of gotten about as big as they can get and started looking outside and going out and really acquiring physician practices and other healthcare providers. And so this type of vertical integration where provider or hospitals are kind of able to extend their reach without actually having to merge and consolidate was kind of another way of a hospital really entrenching its market dominance and its market presence. Across these first 2 waves of consolidation, we've done a lot of research, and so we know pretty clearly that prices go up, healthcare spending goes up as well, and quality and access to care either roughly stays about the same or in many cases actually gets worse. And so it's clear that we're spending a lot more and not getting anything else. So that brings us to our third wave of consolidation, really where we are now, which started roughly 5 or so years ago when private equity companies and other corporate actors really entered the healthcare market space, particularly with physician practices. Private equity has been something that's been around for decades and decades and has had a long history of acquiring non-healthcare entities. And so I think a pretty natural question is, what is it unique about healthcare that made private equity decide to come in the last couple of years and really drive this third wave of consolidation that we're really in the midst of right now? The second thing we should really think about in private equity and this wave of consolidation is we know from the first 2 waves that things don't work out that great. And is private equity going to be any different? So are we going to have the exact same price increases, reductions in quality that we've experienced for other types of providers, or is there something unique about private equity? Here, I don't think the answer is quite as cut and dried as maybe we would think. So if you're a private equity company, the incentives are a little bit unique. So many PE firms have pretty actually strict guardrails in terms of how long they can hold on to a company or an asset. So if you're a PE firm, typically you have roughly 5 or 6 years to actually flip the investment or the physician group, say, for example, that you purchase to somebody else. And so the reality is that if you're a PE company, nobody wants to buy a physician group that has low quality and nobody wants to go to. And so actually there might be a pretty strong incentive to improve quality of care. For PE firms, another kind of common way of really increasing the value of a company is doing some sort of business modernization. Healthcare is an industry where many physician practices still rely on paper records, and they have this thing in their office called a fax machine that's used very often. And so, maybe there is some room for actually improving what we get, even if we do spend a little bit more. But I think we should also think not just what happens when the private equity company comes in and acquires a physician practice, but also just as much what happens when the PE firm exits and what happens during that exit. So in healthcare, all roads lead to a hospital, and now many of those roads also lead to United Healthcare, and that's kind of a common divestment strategy for many PE firms. And so if PE is just a kind of phase to get to these kind of first two waves of consolidation, and we're going to have probably the same impacts on price and quality, then I think it's especially important that we think about kind of the unique role of private equity and kind of where we are in this third wave of consolidation. So I'll turn it over to Ashish Sweeney to talk about some of the unique aspects of private equity.
Good afternoon. My name is Yasha Sweeney Singh, and I wanted to jump off from where Chris left off to say, the long-standing tension in healthcare between medicine as a profession and healthcare as a business is not new. What's new is the current flavor of this tension, which is the best time to revisit this tension given the rapid growth in private equity investments in healthcare in the American healthcare system. The key concern has always been that physician obligations to their patients might not always align with business obligations to their shareholders. So what does private equity then mean in this context? I'll give you a couple of facts and trends around the growth of PE, and then I'll tell you my thoughts based on the literature so far on why we should care and why we should be paying closer attention. So PE investments in the American healthcare system totaled about $5 billion in the year 2000. In the year 2018, this was $100 billion. And if we look at the last decade in particular, it was $1 trillion with the T, totaling over 8,000 facility investments. So these are quite striking figures. I'll share something else with you. When we look at areas where PE is investing, it's really cradle to grave. So think of fertility clinics, neonatal care, primary care, behavioral health, dermatology, gastroenterology, ophthalmology. You need hospital care. They're acquiring hospitals. You need long-term care, assisted living facilities, hospice, home health. It really runs the entire gamut of anywhere and any setting you could require care. So then, it's a natural question to ask, what does this involvement mean for patients, physicians, consumers, taxpayers, and so on? But before I get to those questions, I want to level set a little bit and tell us really in as simple terms as I can what we mean by PE, how the funds are structured, which will then inform us a little bit about what incentives these funds face, and then how we might begin to get at their implications. So private equity in general refers to an alternate investment class. PE funds acquire capital from institutional investors. Who are these investors? Think university endowments, pension funds, high net worth individuals, and so on. PE funds then take the capital and combine them with large amounts of debt. Now, the debt is often upwards of 60 to 90%. And then this capital and equity together is used to acquire a majority controlling stake in a physician practice or a hospital or a nursing home and so on. So I share these two attributes because these are particular attributes that make PE distinct from other types of for-profit ownership. The level of debt is important to consider because not only is the debt highly leveraged, traditionally these were called leveraged buyouts, but the debt is also placed on the balance sheet of the acquired practice, not the PE fund. So you can imagine a physician practice now has interest payments to service, which has the potential to alter the incentives and the practice patterns because they now have this loan that they're on the hook for. The other thing I'll mention about PE, which Chris mentioned as well, is they have strong incentives to quickly and substantially increase firm value. This is because typically the exit window for PE is in the ballpark of 5 to 7 years, and an exit is necessary for payoff. So PE funds often expect upwards of 20% annual returns, and a large part of these returns to the PE fund it materializes only when you have an exit. And so questions around, what does this shortened investment period, again, do to the incentives? You think of a traditional for-profit owner in the traditional waves of consolidation Chris mentioned, they might not necessarily have that short exit window or investment horizon in mind when they either horizontally or vertically acquire provider practices. So I've already talked about strong financial incentives. I'll tell you one other characteristic of PE, which is they tend to have weaker reputational concerns. They don't have longer-term ties with the practices that they seek to acquire, and neither do they want to remain long-term with the practices that they seek to acquire. So this essentially creates misaligned incentives where PE is in to get in and get out and perhaps make a quick buck doing so. So I've given you this overview. Again, you might be wondering, PE, is it the same as for-profit ownership? There are a lot of private for-profit actors in healthcare. Hopefully the points about their use of financial engineering and highly leveraged loans to structure their financial arrangements for these acquisitions, that and then their short investment time period gives us some clue about the fact that PE might not just be another form of for-profit ownership in healthcare. So now that we have a basic understanding of what PE is, I'll talk briefly about why we've seen this massive inflow. Part of it is, we can think of supply factors and demand factors. Part of it is historically interest rates have been low. This is not true of the current environment, but historically it's made debt a cheaper vehicle to have to finance acquisitions. Historically, not true of the current climate, antitrust scrutiny of these acquisitions have also been low. So together this creates an environment where PE is really undertaking a pattern of stealth consolidation, going unnoticed from the perspective of regulators. On the demand side, we see the practice of medicine is increasingly complex, and I don't think this is a point I need to belabor to this audience. Regulatory compliance, value-based contracting, keeping track of administrative back-end functions and supports. This isn't traditionally what physicians go to med school for, why they get into medicine for. And so as we see the practice of medicine become increasingly complex, PE offers almost a lifeline to these practices. So proponents of PE would say the waste, the inefficiencies, redundancies, and so on in healthcare, let PE come in and take the administrative functions away from physicians, allow them to practice medicine as they were trained to do, as they would like to do. And together, these demand and supply factors come together to explain the recent wave we've seen. So then the question is, how does PE generate revenues? And that's really the question that I spend the bulk of my time thinking about and trying to answer. The short answer is there's no one approach. So PE, often there's a misconception about PE that PE has a cookie-cutter revenue maximization or profit maximization strategy that they apply to a variety of clinical settings, but the reality is far from that. Oftentimes, these PE funds also have very sophisticated in-house consulting firms. They are also led by or staffed with exceptionally qualified individuals who have either had direct experience in health policy or worked at provider organizations themselves. And so I share this to say that the strategies PE employs is deliberately catered to the setting that they're operating in. So the approach that PE might deploy in the setting of nursing homes, for example, which primarily involves leasebacks related to real estate, that's not the strategy we would see PE funds employ in the setting of physician practices, which is where the bulk of my work sits. So I'll give you an example. In the setting of physician practices, PE often deploys what is called a roll-up model of consolidation or a buy and build strategy of growth. Now, for this strategy, oftentimes PE funds come in, try and find a platform practice. Now, this might be a practice that has great brand recognition. They might have a stable stream of patients, perhaps opportunity for growth that PE can help leverage. And after the initial platform acquisition, PE funds, the goal would be to come in and expand market share by rolling up a series of smaller physician practices into the larger platform entity. This is largely the basis of the recent case against PE fund and PE-backed anesthesia clinic brought by the Federal Trade Commission just last week. And so this add-on or roll-up model of consolidation offers PE a couple of advantages. One, the bigger you get, you can benefit from economies of scale. You can make care delivery more efficient, consolidate back-end functions, and so on. But also, two, the bigger you get, the more market share you command. And that allows practices to then negotiate higher prices in negotiations with commercial insurers. So what does the evidence show in terms of PE's effects using these different strategies? Some of my work has shown that when PE acquisitions happen in the space of dermatology, gastroenterology, and ophthalmology, surprise, surprise, prices go up, spending goes up. We also see utilization go up, which I'll agree could be a good thing if it improves access, but it could also represent overuse and unnecessary care and some of the other nefarious incentives. There are also evidence out there that shows workforce changes coming from PE acquisitions. So if you think about the goal being profit maximization or revenue maximization, there are two ways one might go about it. One is increase revenues, one is cut costs. We've seen in a variety of settings now that the way to cut costs is by changing your staffing mix. We've seen that to be true in the nursing home setting as well as the physician practice setting. So I'll wrap up here just to say that to reference back to what Dean Shaw said about PE being maybe a symptom of consolidation, perhaps one big picture question to think of as we share our thoughts with you is, what is the role of public policy in shaping the incentives that PE funds face, that physicians face, patients face, and taxpayers face? PE isn't sort of a static form of the world. PE invests for a 5 to 7 year time period, and then the exit is really what is necessary for them to realize their investment. And so can we learn anything about their exit and what that exit looks like? Is it a sale to a hospital? Is it a sale to an entity such as Optum? Increasingly, reports from financial and consulting firms say that around 60% of PE exits are to other PE firms. And so what does that mean about the sustainability of this form of consolidation? And what is the role of public policy in really making sure incentives are aligned? So I'll pause there and maybe use that as a good segue to Aaron's remarks. Thank you.
Hi, everyone. It's great to be here. Thanks to to Andy for putting this together, for all the colleagues and collaborators, and to Brown University School of Public Health for having me up to participate in this terrific discussion. So I'm a lawyer, I'm a law professor, and so what am I doing with all these sort of data people is, that's part of the vision of the center, is to kind of bring the policy translation piece by actually identifying what are the legal and policy levers available. Like if we have convinced you potentially that there is a problem with private equity investment in healthcare, the question is, well, what do we do about it, right? What if a policymaker comes to us and says, we're convinced, like, please help us counteract the harms of private equity investment in healthcare, what do we do? So that's sort of what I've been focusing my research, and I'll talk a little bit about now. So that's the approach I try to take when it comes to private equity investment in healthcare, is to really think about it both from looking at this concept that Ashish mentioned of like private equity is a symptom. So similarly, whatever loophole or financial engineering or exploited, financial opportunity that PE is seeing as a revenue opportunity for themselves, anyone can take advantage of. Now that it's taught the system that it can do it, a hospital or Optum or any other actor could frankly take that same strategy, and the secondary buyer is going to almost need to keep up the revenue stream and just continue it on. So the point is not to try to uproot PE from the healthcare system, but rather to think about what are the payment loopholes, the financial exploitation opportunities that exist that are being exploited, how to close those loopholes so that nobody can take advantage of them. But also think about what are the systemic legal levers and policy levers that we have to address the harms that we see happening. And there are 3 primary harms. The first is this consolidation concept, right? This idea that the healthcare space is consolidating and PE is accelerating, it's pouring lighter fluid on that trend. So consolidation, cost increases, but also the sort of overutilization, potentially the risks of upcoding, waste, fraud, and abuse. That all goes in these sort of costs, right? These are costs to the system, costs to the healthcare purchaser, to the payer, but to the taxpayer. The second is to the workforce, right? So if this is all kind of part of the physician burnout phenomenon. I know there was a great piece out today by one of your colleagues just talking about the idea that the profession of medicine is not anymore what a lot of people who went into the profession hoped it would be, right? That physicians are losing autonomy. Even though, yes, private equity is providing some capital, physicians are really struggling under a corporate model because they are becoming sort of widget makers, right? They're spending all of their time answering the profit and the revenue generation. And this is creating a moral crisis among the the clinical workforce. Particularly, we're seeing this, of course, among physicians, but also nursing. We have these shortages. And so this is a related phenomenon. I don't know how much, again, empirically it's a related phenomenon, but I think there's a lot of harm to the workforce that's tied up with this whole trend in corporatization. The third harm, of course, is then to patient care. And this is the one that everyone really worries about, is that those other two, of course, affect patient care, but the sort of revenue cutting and the revenue generation, but also the cost cutting that goes into that can look like stinting for patients, or it could look like shorter times with their provider. It could be loss of access. It could mean that certain unprofitable service lines, facilities, or otherwise are being cut down or just closed up entirely, or that these giant consolidated networks are becoming so that you basically don't have a choice, that you have to sort of do business with the PE-owned gastroenterology practice, or you don't have a gastroenterology option in your area. So I think there's a lot of harms to patient care in addition to the ordinary quality harms that we worry about in terms of things like, of course, mortality or outcomes. But there are also access, cost, and other sort of issues there as well. So if we think about the harms, then that sort of points us to, and the revenue playbooks, right? That points us in some ways to a series of policy levers or potential solutions. And so this is where the sort of the legal options come in. So on the consolidation front, the answer tends to be antitrust, right? Antitrust enforcement. The blockbuster FTC complaint in the last few days against the U.S. anesthesia partners backed by private equity firm Welsh Carson, that is exactly, using the tools of antitrust, not just to go after, this isn't looking at a merger, this isn't looking necessarily it's looking at the practice of acquiring a monopoly in a market and then using that monopoly anti-competitively, not just to raise prices, but to keep out competition, and really to use that market power to generate revenue. And where's that revenue going? Well, it's not going to the physicians, right? That gets to harm too. It's not necessarily going to make physicians' lives better. It's not necessarily going to increase their compensation. It's going to the shareholders and the investors. And so that's the sort of systemic harm is one of financialization. And that is that the healthcare system is being mined by financial services companies or financial investors to take money out of the healthcare system, which is primarily taxpayer funded, and turn it into profits for investors. Not to compensation, not to investments in patient care, and certainly not to more patient care or necessarily better patient care. And then, so that goes to the it kind of ties together the consolidation aspect. In addition, there's fraud and abuse laws on the books for getting at the sort of upcoding or miscoding or overutilization that might be, or the sort of self-referral practices that might be driving some of these investments. So that is, there are tools. There's antitrust, fraud and abuse. There are also ways to, through policy, close loopholes, right? So we saw the No Surprises Act get passed in 2020, and that was in response, frankly, to a private equity-driven revenue strategy built on hospital-based physicians' ability to use out-of-network surprise billing as a revenue strategy to an extent that we had never seen in history before, right? So there are ways to close Medicare payment policy loopholes and things like that are drawing particular investments, as Ashish Sweeney pointed out, very strategically, they identify loopholes for ophthalmology. They identify specific payment loopholes for gastroenterology. And if there are ways to find out where to follow that money, then there's ways to potentially close those financial opportunities that are not providing value to patients. And then the other sort of strategy, and I think I just want to close on this before I turn it over to Corey, is that this is not just a federal regulatory. This isn't just something that Congress has to worry about, or the FTC or the DOJ. States have a lot of tools too, and I spent a lot of time talking to states. So one, states have parallel antitrust enforcement authority. So state attorneys general can enforce the antitrust laws. States also can enforce, and so can private actors, fraud and abuse laws. But states have something that the federal government doesn't, and that is the ability to regulate the practice of medicine. So there's this old doctrine called the corporate practice of medicine that was supposed to keep lay corporate entities from controlling, operating, and directing physician practice because it was thought that, that is anathema to the practice of medicine who owes fiduciary and professional ethical responsibilities to their patients. These laws exist on the books in many, many states. They haven't been used in recent decades, except for there's one pending case in California that everybody's watching with bated breath. Against a private equity-backed Envision healthcare. And there is, there's a lot of opportunity for states to strengthen the corporate practice prohibition to get at the sort of contractual management services organizations and the type of agreements that private equity is using to reach in and not necessarily outright buy physician practices, but essentially operate and control them, right? And to tell them what to do and capture their revenues. So that's one area. And then other areas that states can really regulate in this space are physician non-competes, right? This is creating a chilling effect for physicians. Physicians are, they sort of access the capital, but it's sort of a Faustian deal, right? Because then now you sort of owe your firstborn child all your future net patient revenue. And if you ever wanted to leave the practice or speak out, you're going to have to move 3 states over because that is, you're not going to be able to practice, do your non-compete. And you can't speak out because you're bound to a tight non-disclosure or gag clause. So these are all areas that states can regulate, and really only states can regulate for the most part. And so there's whoever is talking to me, I'm like, there's a policy lever for you. If you're a private, competitor, you can bring a case. If you're a state, you can bring a case. If you're the federal agency, you have some enforcement authority here. If you're Congress, well, I have a laundry list for Congress, but we can't just sort of say it's all on Congress's lap, because it isn't. So I think that's the last point I'm just going to close with, is that there are policy levers at every level, in every branch, and so that is the hopeful thing. The less hopeful part is all of this is a bit whack-a-mole, right? It does have a feeling of like, oh, we're going to chase this loophole. Of course, private equity will have moved on to the next investment opportunity. So it is incremental. It is not sufficient. It's not a silver bullet. If anyone wants to talk silver bullets, that's a whole nother topic. But it's all stuff that can be done, and so I think it should be. All right, I'll turn it over to Corey.
Good afternoon, everyone. My name is Corey King. I'm the Acting Health Insurance Commissioner. I lead the Office of the Health Insurance Commissioner. And as someone who holds a master's degree in public policy from Brown University, I could not agree more with you, Andy, that policy translation is important. I'm thrilled that the university has created this center because I have a demand for evidence-based research, and I need to translate that into policy. So I look forward to continued dialogue and synergies there. I'm going to speak to some of the regulatory levers that the state has. We actually have some experience in this state involving private equity, particularly what happens when private equity divests from an asset that I'm going to speak to. But just a little bit about the Office of the Health Insurance Commissioner, since I have to talk up my own agency. We have a very significant mandate. We're the health insurance regulator, but one of our purposes is to view the healthcare system as a comprehensive entity and to direct insurers towards policies and practices that address efficiency, quality, and access. So we're very concerned about issues of market structure and market behavior to the extent that they impact expenditures, quality, access, and the financial stability of the healthcare system. Because as prices go up and expenditures go up, that drives up your premium. And to the extent that the largest insurer in America is collectively the employer community, and some of Chris's research has shown this, and it speaks to what Dr. Jha said earlier. Increases in your health insurance are a form of compensation, but they're coming at the expense of wage growth, and that's something that we should be aware of. So Rhode Island has a number of regulatory touch points where the question of private equity ownership and effects can come into play. I have colleagues here from the Department of Health. I'm not sure if anyone from the Attorney General's office is here, but the Department of Health in particular oversees changes in effective control. So they regulate the licensure of and oversight of healthcare facilities. So if there's going to be a change in the ownership of a healthcare facility, that could be a hospital, a nursing home, an ambulatory care facility, the Department of Health has to approve that. Noticeably excluded from that are physician practices. We have a very robust Hospital Conversions Act, such that any changes in at least, I think it's 20% or greater ownership stake in a hospital has to receive the concurrent approval of the Department of Health and the Office of the Attorney General. And there are a number of review criteria that each of those agencies is held to. For changes in effective control, the Department of Health, working with the Health Services Council, and Sandra, you can correct me on this later if I have it wrong, has to consider the character, commitment, competence, and standing in the community of the proposed owner, and can examine any previous enforcement actions and behavior of that owner. So it's an upstream, at the time of acquisition type of oversight. Downstream, if private equity is in the market and they're engaging in market behaviors that may increase prices, well, or reduce quality, that can be addressed through regulatory levers on the healthcare purchasing side. So Medicaid is a dominant payer in the nursing home world, where we do have some private equity market penetration in Rhode Island. Medicaid is a major hospital payer, so Medicaid can put in place quality requirements, quality withholds. On the commercial health insurance side, we have a history in Rhode Island of implementing a hospital price growth cap. So price growth caps or even price caps can be used to mitigate some of the pricing pressure that would be exercised due to the incentives that were described earlier. I want to briefly just touch on a previous episode in Rhode Island of what happens when private equity seeks to divest. So about 10 years ago, Prospect Medical Holdings, which was backed by the private equity firm Leonard Green and Partners, purchased two of Rhode Island's hospitals, Roger Williams Medical Center and Our Lady of Fatima. In 2019, I believe it was, the company sought to divest its majority ownership stake in Prospect Medical Holdings and sell to the CEO of Prospect. There are ProPublica articles on this. You can read them. I'm not going to go into great detail. But at the time that the hospital conversion was being considered, it came up to the Attorney General and the Rhode Island Department of Health. And I think the Attorney General of Rhode Island has really excelled in this space. At the time that the hospital divested, the Attorney General was able to impose very strict conditions on that conversion, including requiring that Prospect Medical Holdings and Leonard Green put money, $80 million, into an escrow account to fund continuing operations and capital expenditures at the hospitals during the 5-year monitoring period that's required under the Hospital Conversions Act. So as someone who takes an interest in really good public interest regulation, I think that offers a really important specific example, a case study, if you will, to how states can address various dimensions of this question. So in general, I would just conclude by saying states in particular, as Aaron made the point, have a number of regulatory tools on the table. From the OHIC perspective, we regulate commercial health insurers, but we can require them through their contracts with providers to try to mitigate any potential harms that would occur due to market behavior. But getting back to Andy's earlier point, if we're making administrative decisions or promulgating regulations or advocating to changes in law, we need to do so on a good evidence basis. So your research is really important to us. And I'll hand it back over to Andy.
Okay, thank you so much, Corey and the other panelists. Let me start with the question probably best targeted towards Chris and Yashaswini. So both of you talked about the evolution of private equity in healthcare, but could you maybe speak a little bit about, what are some of the recent trends in private equity acquisition with respect to markets or specialties or sectors, and what that might mean for what we should expect in the coming years?
Does this work? Yes. That's a great question because PE investments certainly aren't happening at random. They represent strategic selection of investment opportunities. And so if we look at geographically in the US, there are certain hot pockets that jump out immediately if you look at a map. Arizona, Texas, Florida, these are states with a large amount of PE penetration, also the Northeast, and then certain pockets in the Midwest. Particularly in the space of physician practices, there's an interesting wave with respect to clinical focus. So the early wave of PE started with acquisitions in hospital-based specialties, so emergency medicine, anesthesia, radiology, and so on. And then in the last 5 to 7 years, perhaps, there was a shift towards procedural specialties. A lot of people are aging. A lot of people need skin biopsies, cataracts, colonoscopies, and so on. And so, lo and behold, PE is in dermatology, gastroenterology, and ophthalmology. The current frontier seems to be primary care and behavioral health, investments in entities that are engaging in those risk-sharing, value-based contracts. And so I would think that's an area to pay closer attention to.
So maybe one way to think of this is to put on your PE investor hat, and you've identified a specialty that you want to go into, such as dermatology, where there's lots of just add-on things that you can just say, we're going to order more infusions or more treatments, and patients are probably much, for the most part, say yes, I'll do that. And there's a lot of new drugs that you can get paid for administering those drugs, and that's actually probably the largest part of your revenue. And so you want to expand into dermatology. And I brand new to Rhode Island, so I don't really know the market, but I'm going to stick with what I know of California. And so you could go and say, I'm going to enter the Los Angeles market, and I want to acquire practices and negotiate prices. But if you go into Los Angeles, you're going to acquire one dermatologist or two dermatologists, but there's still going to be 15 other ones there. And so when you're sitting down with the insurance company, they're going to say, well, you don't really represent our market that well. But if you can say go to Fresno, which instead of being the huge city of Los Angeles is kind of a medium-sized town, you acquire 2-3 dermatologists, and all of a sudden you've got the entire market. And so when you sit down with the insurance company, you've got just a ton of negotiation power. And so there's kind of these pockets of sweet spots where not just PE, but other investors, but PE has been maybe exceptionally good at doing, that make really attractive investment opportunities. And the reason, or if we're thinking about reform, we should think about what makes these sweet spots so attractive, and what are the payment or other policy levers that not just for PE, but for consolidation across the board can address these factors.
So I invite the audience members to come and come to the microphone if you have questions while we're waiting for people to overcome their shyness. I'll keep going. So Aaron and Corey, I'm just thinking about the FTC action, and that Ashish mentioned and several of you brought up. I'm interested in hearing you think about some of the scenarios of this ruling, and depending on which way it goes, what might this mean for not only private equity investment, but just further activity with respect to consolidation.
Yeah, so the complaint was just filed, I think, a week and a half ago. FTC versus U.S. Anesthesia Partners and Welsh, Carson, Anderson, and Stowe. And it's if you read the complaint, even if you're not a lawyer, right, because you read the complaint, it is like riveting, right? It's a story of how private equity consolidated, strategically did all the things that Yashaswini talked about, like a strategically, serially acquired monopoly power in Dallas, in Houston, in Austin, frankly, across the entire state of Texas, and then use that power to raise prices, edge out competitors, buy them off, divide the markets, do all the things that are frankly just patently, anti-competitive. And so I think what's interesting about this is it's the first case that's ever been brought against, I think, a private equity-backed physician practice strategy, it's alleging a traditional horizontal consolidation argument. So you're not having to prove that there were efficiencies of a hospital buying physician practices. This is just we're just going to monopolize the anesthesia market horizontally across Texas. And so that's interesting. The other thing that's interesting is it's using this sort of serial acquisition as a whole. The stealth consolidation has already happened. And so it's not about trying to break it up. Well, it may break it up. But I think that what's interesting about it is it could chill if it's successful, right? If the FTC wins and the court agrees with them that there's been an antitrust violation, or there are so many different claims, but an antitrust violation there, I think private equity companies are watching very carefully because they realize they need to either pursue a different strategy, start getting out of the ones that they already are in, because this has been their strategy across the country. So if this goes down, then a lot of other markets are vulnerable to a similar trend, and I think that they're certainly paying attention. So this is an example of like strategic enforces one market, one specialty, but it'll send a very clear message across the industry, and they see this as one of their top headwinds or challenges moving into the next, moving ahead in the next year in terms of what their strategy is going to be.
I have nothing to add to Aaron's analysis of antitrust law.
May I add a quick point? So their add-on strategy is no secret. If you go to a PE firm's website, they'll proudly declare, look, we had 400 add-ons in the last year. Look at how successful we are in making the firm successful. That's all well and good, but the firm being successful is not the same as the physician or the patient being successful. So yeah. I'm glad the FTC is paying attention.
Well, and I think one other point is that we were worried that the FTC or the antitrust enforcement authorities are not paying attention to these because they quote unquote fly under the radar. Each individual, like 2 or 3 practices that are rolled up, they're too small in dollar amount to ever be reported to federal antitrust authorities because they are not $111.4 million in size. And so that is the threshold under the Hart-Scott-Rodino Act for anything to even be notified to the federal antitrust authorities. So the fact that the FTC went and used its investigative authority to go total all of the serial acquisitions and watch this market behavior, I think is it's really important, because I think they've just been taking advantage of the fact that they can do this all under the radar and nobody's watching. And so that's really helpful.
Excellent. Ron.
First of all, this on? Can you hear me? This is a great panel, so thank you for doing this, Andy. I guess this question maybe I'll start with Yasha Sweeney and then maybe you distribute it to wherever it should go. But I was wondering if there is a PE presence in the biotech sort of late stage development space, because that seems sort of ripe for the next wave, I would think. So I'd be happy to hear your thoughts about that.
That's a great question. My understanding is the biotech space sees a lot of venture capital, which is similar to private equity, but a little distinct in their incentives. PE will often go after an established practice and aim to grow it to its potential, whereas venture capital might be interested in a minority share, not a majority share, but then really target those high-risk, high-innovation type ventures. But I'll admit, it's not an area I've spent a lot of time thinking about.
I have heard that PE is moving into pharma, particularly on outsourced clinical trials, which is like, again, follow the money. Where's the revenue play there? But yeah.
Thank you.
Alex.
Hi, everyone. My name is Alex. I'm a medical student at Brown, and I studied health economics here as an undergrad, so I really appreciate everything the panel had to say, and thank you so much for your time, and really excited about this center. I had a question. I think one of the things that has been interesting to see in the past few years here is, just the dichotomy between a lot of the work that health economists and public policy makers do and stuff that I've studied for a bit, and then on the other side of that, the medical school and being in the hospital all the time and seeing kind of patient by patient and how clinicians practice. There's such a divide there, I think, in a lot of ways, and I'm really thrilled that CAPER's making it a priority to make crosstalk between researchers and translating that into policy priority. But I'm also thinking about between making that translation between researchers and not just physicians, any healthcare provider, physicians, nurses, social workers, those that are kind of on the ground, because I think that in a lot of ways there can be, I think providers sometimes can lump all of those, all policymakers, researchers, all in one kind of larger entity of someone that's outside of the practice of medicine and is hostile to that in a lot of ways. So I think finding strategies there would be interesting. I'm interested in hearing your thoughts on ways we could, as health policy researchers, ways to make that crosstalk happen and ways to clarify misunderstandings that can arise.
All right, thank you, Alex. I think, historically, many of us have had strong clinical collaborators. I know Yasha Sweeney does, and Chris has, and I have as well. And I think you heard from several people on the panel, not just what does this mean in terms of spending or even patient outcomes, but what does it mean with respect to the physician workforce and physician practice? So I think that is a great point, and this holistic view that it's not just, payers and patients, but, we can't ignore the role of clinicians and clinician workforce because, there's short-term effects there with respect to, as Yasha Sweeney said, perhaps substitution of labor that could be important. And there's longer-term issues that Aaron mentioned with respect to quality of life and, the issues around burnout and et cetera. So I think these things are all in play, and I think you can hear from many of us here that it's certainly front of mind in considering these issues. Please, yeah.
Thank you. Good afternoon. And as has been said before, what a wonderful panel and wonderful presentations and discussion so far. My name is Sandra Powell, and I'm one of deputy directors at the Rhode Island Department of Health. And as Corey said, my team actually spends a lot of time in this space in terms of the regulatory matters. The prospect charter care, one that Corey spoke about, actually is back in front of the health department for a new iteration of both hospital conversion and CEC, and had a chance to talk with Chris. So some of that is available on the website in terms of the change and effective control piece. But one of the questions that I really had was, were there any data or findings? I think it was Professor Singh who spoke about in that 5 to 7 year cycle that often the private equity firm has done what they've come to do, and another private equity firm may be interested in moving into that space. So I was very curious about that. And one other thing I'll add, we're very, as Corey said, we are not, we don't regulate practices, but certainly hospitals and nursing homes. So we're also very interested in the nursing home space and just issued some regulations on Monday that go to the incentives, not trying to target the private equity firms, but just the incentives that happen in that space. So I was curious about the continuation. Thank you.
Thank you for your question. I forget if I explicitly mentioned this in my opening remarks, but I guess one important thing about PE is private equity. By nature, these are private investments, so there are no disclosure or reporting requirements. And unfortunately, a byproduct of that is, as researchers, we are really lacking data on when acquisitions happen, where they happen, what are the different entities involved in the different complicated ownership arrangements, because PE funds are never outright owners of practices. There are often very, very complicated hierarchical relationships between management services organizations, PE funds, and so on. And so not only does the lack of data pose a challenge in us identifying these trends, but also in identifying what does divestiture look like. If PE is selling 5 to 7 years down the road, who are they selling to? This unfortunately is not information that's systematically tracked. What I shared earlier was based on, I think it's a report from Bain Capital about investments in healthcare in general. 60% of them, PE exit looks like sale to another PE. But whether or not those precise numbers hold in the physician practice space is something unexplored, but something that I'm working on with the team at Caper. So hopefully, unfortunately, this is painstaking manual work. So I do want to give a shout out to a wonderfully talented team of researchers here at Caper who make the work possible, but it's still work in progress.
Thank you. Geronimo.
Hi, yeah, I'm Geronimo, first year HSR PhD student. This is a great panel. I'm very excited for the center here. My question is, we've talked a lot about kind of how we stop PE. And we started with it's just kind of a symptom. So if we do stop PE and we could just end PE tomorrow, it just seems like there would still be somebody to come in and take its place, whether it's venture capital or somebody else, because there appears to be a demand for what PE is selling to physicians or whoever they're purchasing from. And so I guess my question for the panel is like, where are we going to get the capital that is obviously in demand? Is it the government that is supposed to come in and provide the capital that is in demand from these companies? And because that, to me, appears to be the actual cause.
So I'm going to turn it over to one of the other panelists to answer that specific question, but I thought it was worth just mentioning, I know the topic of discussion today is private equity, but it's important to remember that nonprofits have leveraged broken market structures and increased costs and led to suboptimal outcomes. So we have to bring a broader perspective to that as well. I just wanted to remind us of that and just pose a really brief question to other panelists that maybe they can answer in the context of yours. And that is, if the intended life cycle of the private equity investment is 5 to 7 years, how can policymakers ensure that if they approve a change in ownership or an acquisition, that the private equity leaves the asset, the facility, in at least as good of a condition as they found it, given the business model that they run by?
So maybe one way to think of that question is that nobody's forcing physicians to sell to a private equity company, and physicians across the country are voting with their feet that they do not want to be an independent physician. And you can argue what is the practice environment that contributes to that, and how much is this, I really want to be an independent physician, but I just can't make it work under current payment models or regulatory environments. But half of physicians work for a hospital system, and 30 or so percent work for an insurance company, private equity, or other corporate investor. And so one thing that could be done is just to say, well, we recognize that it's hard to work for be an independent physician, and so we're going to pay you more if you're an independent physician, or we're going to ease your regulatory burden. But another way to think of it too, in kind of the private equity role, is that that you can go to a physician and say, look, I know you're going to sell to a hospital, or you wanted to sell to a hospital. Come join, let me join you, and together we're going to do a bunch of stuff and raise your revenue, and we're both going to make a lot more money from the hospital. But at the end of the day, you're going to end up working for the hospital, or your group's going to be owned by the hospital. If we were to think about the ways that we pay hospitals versus physicians, then maybe that incentive to end up at the hospital would be quite a bit different and would be much flatter.
Yeah, I think that is a big conundrum, right? It's like, where's the capital going to come from? I think there's one could wave a magic wand and say, well, the government should just pay. I mean, our government, right? We almost shut down the government a week ago. So I think that is a perennial question. I also think that though there may be some parts of the policy debate that's let's uproot PE from the healthcare system, I think that's that ship has sailed. What was the number, $1 trillion of investment? So it's about, how do we manage the risks and the harms? So is there a way to access the capital, but put some guardrails around the worst harms to patient care, to physicians, and to costs and consolidation? Of course, will that make it a less throw gravel in front of the momentum? Yeah, I think that's actually something worth doing, even if it sort of just slows down the worst effects of it. And it might slow down the volume or the speed of the capital coming in, but it probably wouldn't stop it altogether.
Can I just comment on this question of capital? Because this does strike me as something that is unique about private equity, that, the roll-up strategy, it requires a lot of capital. And, hospitals have done lots of, vertical integration, but still, it's a level of investment that I think there's very few players in healthcare that can manage to pull that off. And it seems like that is something that's distinct about private equity, being able to leverage all that capital. And I do wonder if in this new interest rate environment, if we should kind of expect a natural slowdown. because the opportunities for those kinds of deals are just not nearly as lucrative as they have been in the recent past. You don't need to comment. Please go ahead. Yeah.
Hi, thank you so much for the panel. It was fantastic. My name's Ishan. I'm a research assistant here at the School of Public Health, and I just had a question going to something that you guys had mentioned before, which is that, recent policy, especially at CMS, value-based care models, is kind of incentivizing almost the consolidation. And I know from speaking to many providers, they're very interested in value-based care models, but what is a way that we can deliver these experimental models, be able to play out these experimental models while not incentivizing this type of payment structure, especially because I know recent ACO models have been a lot more stricter on reimbursements to providers. There've been a lot more stress. So how can we kind of manage that line? Thank you.
Do you want to start, Chris?
I mean, I think building my earlier point, I think a lot of these value-based payment models are actually what makes working for a hospital or private equity company much more attractive, and let the PE company or the hospital deal with CMS or an insurer, and let me just see patients.
Yeah, so we've actually looked at value-based payment as a mechanism to try to improve affordability by managing healthcare cost trends. And I think there's a way of structuring it where you can perhaps overcome some of the concerns of the consolidated provider using its market power to leverage prices, where the Office of the Health Insurance Commissioner has a cap in for instance, a lot of organizations are organized as accountable care organizations, and they're functioning under total cost of care contracts with a budget target. And we actually cap the annual growth in the budget target. So it's not a quantity that's subject to unfettered negotiation. It has to be capped. So there are ways of doing that, but I do think there are some limitations to value-based payment, and I'll stop there.
Okay, excellent. Last question.
Hi, I'm Kate Bramson. I'm here at the School of Public Health after a career in public policy following a journalism career. And as we talk about private equity, it sounds a lot to me like what has happened to our journalism industry. And I'm wondering if there are lessons learned from industries that are further along than healthcare in terms of where private equity came in. We look at the collapse of our newspaper industry, our journalism industry. Are there policy lessons we can learn from what happened at the end of that tail that would help us figure out what policies to address now in the healthcare industry to prevent some of the deep collapse?
That's a great idea. Journalism, independent journalism is one area. The other one's housing, right? There's been a lot on sort of private equity buying up housing. So I think that in some ways that sort of like whatever policy levers we deploy, again, on the one hand, it's sort of private equity specific, but it can't just be about private equity. But there are some things that I think that would help. And one is transparency, increasing the transparency of private equity's movements into an industry, regardless of whether it's healthcare or not, because again, we can't study it, we can't report on it, we can't know what's happening unless there's more sunlight. And I think the other thing would be, the other policy that seems to have got a lot of traction, but not enough to get over the finish line, is to change the tax treatment and advantages of private equity, the carried interest loophole. We can thank Kristen Sinema for not having a narrower carried interest loophole from the Inflation Reduction Act. But I think that keep pushing on that. It wouldn't solve the problem. But again, it's about just adjusting some of the incentives, leveling the playing field, kind of a thing for private equity.
I'll add just a brief note to Erin's comment. I've thought a lot about what we can learn or whether we can learn something from other industries. But if you look at the literature on PE in, say, fast food or Petco, Subway, all of these have PE backing. But healthcare is just very, very different from how these industries operate. The most stark difference being if you get a bad Subway sandwich, quality can be a disciplining factor, but quality in healthcare is so nebulous. And so we don't really see the same effects or the same disciplining effects you would expect to see in another industry. So just something to keep in mind, I guess, as we look to other industries for lessons that we can apply to design these guardrails in healthcare.
All right, excellent. Well, I want to thank this slate of outstanding panelists for a really robust discussion and thank the audience for your engagement and questions. And we hope to have many more interactions like this. So thank you.